I am actually your last speaker, so I am going to pull up my slides. I'm going to wrap it up by talking about something that's near and dear to my heart, which is clinical trials. And why am I doing this? Because I think there are so many patients who miss out on opportunities for new and exciting, groundbreaking therapies because they don't understand what clinical trials are. As someone who has done this now for the past 25 years, I have been involved in conducting the clinical trials for all of the drugs that Dr. Ma was talking about, including the hedgehog inhibitors, as well as the immunotherapy agents, the cemiplimab and pembrolizumab. If it were not for clinical trials and patients who were willing to think out of the box and say, yeah, you know what, the standard therapy that you have is okay, but can we do better? We would never be able to move science forward. And so tonight, I'm going to briefly talk to you a little bit about clinical trials and why they are so important to consider in your treatment regimen should you have to talk to an oncologist about locally advanced or distant non-melanoma skin cancers, or really any cancer for that matter. So why is clinical research so important? Well, because these are an opportunity for you to be able to be treated with the latest, greatest, and most novel therapies that are available. Clinical trials are run so that there is a set amount of patients that will be enrolled. And once that clinical trial has been enrolled, that trial closes and that medication is no longer available to you. So when we as oncologists talk to our patients, we talk to them about studies that we get excited about because we think that these are drugs that may be better than what's currently available as a standard of care. Why is this also important? It's important because it gives you another line of therapy, whereas if this trial were not available to you, instead of having, let's say, 3 treatment options, now you have 2 because there are 2 standard of care options. And yes, you do know what the treatment responses are, but can you not do better? And so that's why it's always worth listening and bringing this up to your physician about, can I participate in a research study? And if so, what are my options? Because many times there can be multiple types of clinical trials that you would be eligible for. The other benefit is that you're helping mankind. It may not only help you and save your life, but it will also impact future patients with your same type of disease. We also know that cancer patients who participate in clinical trials live longer. Why do we know that? Because going back, I can't believe it's already almost 12 years ago, but 12 years ago, we did this and we looked at all of our clinical trial participants who participated in melanoma trials. And what we saw was that patients who participated in clinical trials truly lived longer and better lives. So let's talk a little bit about what kind of clinical trials there are for patients. And the first is that it's a treatment trial, meaning that you've got a disease and we're going to give you something that's going to impact its outcome. The second is prevention trials, where these are trials where we take populations that are at risk and say, because you have X, Y, and Z, whether it's a genetic trait, a family history, we are recommending that you take this particular type of medicine or do this particular type of life change in order to impact outcome. Early detection trials and screening trials, again, these are ways to try to prevent disease. Diagnostic trials look at new and novel ways to better identify disease. And quality of life studies are also very important. You know, when we did our very first studies for skin cancer, looking at squamous cell carcinoma and using cemiplimab, what became very obvious in those very first studies was even before the patient's lesions got better or their tumors got better, all patients who had pain and were going to respond had a very, very rapid response and reported that their pain got almost instantly better. And so because we conducted these quality of life studies, we were able to say that because patients with squamous cell carcinoma can sometimes have a lot of discomfort because they have a lot of open wounds, or the lesions may actually grow into a nerve. These quality of life studies provided us with the insight that when patients come back and say, hey, you know what? My pain is better, even if we don't see a change in the tumor, that may be something very meaningful. So understanding the phases of trials also helps you to identify if it's a trial that you would like to participate in. So trials are divided into phase 1, phase 2, and phase 3. A phase 1 study is a safety trial. So this is essentially where we take a medication that we've looked at in the laboratory and now provide it to humans to see exactly what is the side effect in humans and what is the correct dose. Phase 2 studies happen after you know the proper dose and you know what the expected side effects are. And now you look to see how effective it's going to be within a particular tumor type. And finally, phase 3 studies take the data that we obtained from phase 2 studies and compare it to what is our standard of care or a gold standard. And so when patients participate in phase 3 studies, these are usually randomized blinded trials, which means you don't get to pick what treatment you get. Your doctor doesn't get to pick what treatment you get. And it's a flip of the coin to decide which treatment you get, knowing that if you get, let's say, tails, you're getting the standard of care. So you're not getting anything that's inferior. But if you get heads and you get the new therapy, you may actually be getting what's going to become the new standard of care, or it will be just as good as the standard of care that we have and will not supplant our currently accepted therapy. So that's how those trials work. And how do we design research studies? Well, we sit and we ask a question. We look at our target population. We develop a plan. We talk to our statistics folks who give us these numbers and tell us how many patients we need to put on this study in order to acquire meaningful data. And then we do the study here at the end. This is the actual study. This is what patients participate in. And then we analyze that data and come out with our results. These are the key elements to a trial. Every trial has a rationale. Why are you doing it? Why is this important? Why do we think that this medication is going to be effective? And what are our goals? What are our objectives? What's our study population? Many times when we do studies, we have what's called inclusion and exclusion criteria. So certain milestones that patients need to have in order to participate, as well as things that we don't want patients to have. If we have a drug that is very immunosuppressive and lowering of your immune system, well, we don't want patients who have active infections to participate, because by lowering their immune system, their infection is going to go out of control. And so having an infection that is uncontrolled would be an exclusion criteria. We develop a study calendar so people know where they need to be, when they need to be, and how they need to be, and what exactly is going on throughout the entire course of the study. We talk about what medicines you're going to get, what are expected side effects, and how often do we assess those, and also supportive care. What are the procedures or medicines that you may need in order to get you through this study. And so I put these up because to me, these are some of the key questions that patients need to ask their physicians about when they're talking about a clinical trial. And so the first one is, are you adding a new medicine to a medicine that's already approved? So many times we try to build on the cornerstone of a particular medicine that's already FDA approved to try to make it better. So for example, if we're talking about non-melanoma skin cancers, that cornerstone would be an anti-PD-1 immunotherapy medicine. And we are now looking at what can we add to that medicine to make it even better than it already is. Another question is, are we just going to be giving you a new medicine that's not FDA approved? Again, providing you with an opportunity for a new drug that may be the next hottest thing since sliced bread. And what are the benefits and what are the risks of doing that? What's also important is, what is your time commitment? When you participate in a trial, you are really monitored very, very closely, much more so than when you get a standard of care medication, because we know what's to be expected. And so sometimes we have you come for more office visits than normal, again, just because we're being overly careful. What is your time commitment? And will you be reimbursed for your transportation or your parking? Because again, remembering you may need to make multiple visits, you need to know whether that is going to be covered by the study. And many times it is. Who do you call if you have a problem? You need to really know what is the best number 24 hours a day to find out, if I have a problem, who can I talk to? For younger patients, we need to talk about whether it's going to affect your fertility or not. And should you have fertility harvesting done prior to participating? Where else is this trial being done? And what are your other options? Because it's also very important that you know, yes, this is a trial. Yes, I'm eligible, but what else is there? What else is out there? Because sometimes things do fit your lifestyle better. Informed consent is just the process of us as medical personnel explaining the clinical research in complete detail so that you know about the investigational medicine. You know that participation is optional. If you decide you want to participate in a research study and you go on study and you sign consent and you start taking, let's say, pill X, and you decide 2 weeks later, you just really don't like how you feel when you take this medicine, you can withdraw from study at any point in time. And it's important for study patients to know that although you are committing to participating and going through all of the screening tests and all the visits, you are free to withdraw and say, no, I've had enough at any point in time. You need to know what the risks and benefits are. You need to understand what the alternatives are. And again, you need to know that you're going to be investing a lot of time, but you are going to be getting an awful lot of good care. So I talked a little bit about screening, and screening is essentially the time before you start taking medicine after you sign the consent form. So once you sign the consent form, you are now officially on study. And before you start your medicine, that's the screening period. That's where we get blood work. That's where, if a tumor needs to be biopsied, if you need to have scans done, that's all considered screening workup. If you meet the criteria, you are then, quote, eligible, and you are then given a treatment date. During the trial, you will have regular assessments. You will always get questioned about what side effects are you having? When did they start? How bad are they? When did they stop? If they stopped, what did you take? Were there any new medicines that you're taking? We will always review all of the medicines a patient is taking, as well as any medicines the patients may have stopped. If for any point reason there is a change in what's being done in the study, for example, we decide, oh, we need to take a photograph of your skin lesions, you may need to reconsent saying, yes, I now give you approval to take pictures of my tumor. And so these are all the things that occur during the trial. After the trial, whether you go off a study because you've now finished the treatment and you have no more disease, or your disease just didn't respond to this treatment, or you just said, yeah, I've had enough, I want to come off study, we will continue to monitor you somewhere between 30 and 90 days for any side effects. And this is for safety reasons, keeping in mind that you are on a research drug. And so we need to make sure that you are safe. Some patients can remain in follow-up for years if they're agreeable. And again, why? Because this is what we call survival data. So we want to know how well you did because you took this particular drug. And we do keep all study records for 7 years. After the study has closed, they are kept locked and secured. In case the FDA wants to look at any of our data, we can provide that to them. So why don't more patients participate in clinical trials? Well, the number one reason is because nobody asked them to. 62% of people said, nobody talked to me about research. Only 15% had no trial available. 13% said no, they weren't interested. And 2% had no insurance coverage. But really, the bulk of the reason is that doctors just didn't talk to their patients about it, and patients didn't ask their doctors about it. So why don't doctors discuss clinical trials? Well, because it takes time. Talking about a standard therapy is very straightforward and very quick. And these are the side effects, X, Y, and Z, and you'll come in every 3 weeks and so on and so on. When you talk about research, you have to take time to explain, why do we think this drug is important? How did we develop this drug? How does this drug work? What are the expected side effects? And what is the patient's time commitment? Some patients don't want to participate because they think their family doesn't want them to participate. Well, the answer is, let's get the family on the phone and let's get everybody together and let's talk about pros and cons. And many people just think that the standard treatment is the best treatment, which is totally not true, because we can always do better. We don't cure 100% of our patients. And when we do, the standard of care will be best. But right now, looking at options is always a good thing to do. So these are just a brief overview of some of the trials that are currently open to enrollment for patients with non-melanoma skin cancer. And we're looking at things that are topical, like retinoid, rexinoids, and TLR, which is a receptor, different types of creams that are immunologic in helping combat tumors. Sometimes we can inject tumors with viruses. Sometimes we give them systemic therapy. Sometimes we look at immunotherapy and chemotherapy. Many of our current clinical trials are building upon that cornerstone of anti-PD-1 therapy, because we know that basal cell squamous cell and Merkel cell cancers all respond very well to immunotherapy. And so we're looking at, how do we make that better? And we think that making that better means adding another agent to that regimen. There are also some trials that are looking at tumor infiltrating lymphocytes, which is actually a process where a patient will go to the operating room, have their tumor taken out. We then take that tumor, put it in the lab, grow out the patient's T lymphocytes. These are the killer lymphocytes that are trying to kill off the tumor, grow millions and millions of these lymphocytes, and then give them back to the patient after they get what's called lymphocyte depleting. So we get rid of the patient's normal lymphocytes through a chemotherapy regimen and then give them back these helpful T infiltrating lymphocytes. This is all being done on clinical trials. We're also doing clinical trials, in particular for organ transplant patients, since we talked to you about how these are patients that are more prone to getting skin cancers. Well, we're looking for ways to try to target these cancers without impacting their organ that's been transplanted. And finally, I hope that I was able to provide you with some insight and convince you that clinical research is so important because it really does change lives. It may change yours and it may change the future. Thank you.